Again, my name is Martin Pham. I'm a neurosurgeon at UC San Diego. And again, thank you to the Seattle Science Foundation for putting together another wonderful agenda and for inviting me to talk on this topic. So I will start off with this. This is a video of Figure Robotics, Figure 1 humanoid robot, right? So it's connected with OpenAI's speech-to-speech reasoning. So it's not a movie, this is real life. And the human is going to ask the robot, can you get me something to eat, right? And so the robot has cameras so it can detect. Then it goes, Figure 1, can you do something with this trash? And so it sees the basket and it throws away the trash. Then the human goes, Figure 1, what would you do next with this plate and cup? And with the camera, it detects, well, there's a dish rack. So then it makes sense then to put the cup and the dish away. Now, for the purpose of this talk, spine robots, however, can't yet get you something to eat, throw away your trash, do your dishes, or other important things in daily life, do your laundry, taxes, find your misplaced Amazon packages, keep that person in front of you from reclining back into you. So all these are quite unfortunate. Other limits of spine robots, hardware limits, right? Right now, most of them are about putting in pedicle screws, registration of levels for the software, the acquisition of the robotic system, benefits, so when is the robot actually worth it? And then you can also think of limits in terms of what you want to do as a surgeon, right? So where you want to operate, are there anatomical limits, the diagnoses that you want to treat, right? The procedures that you want to do, right? And of course, all of these are interconnected. I drew these lines and I immediately thought of this meme here. So, the talk is meant to discuss the limits, right? And I realized in putting together this talk that really the only way you can define the limits is really first by defining what's possible, right? So what is possible with a robotic system? Because once you define what's possible, what's left are the limits. And you might be surprised about what is actually possible, right? Especially after the first two talks that Rick and Roland gave. So, through this talk, what I want to show is what is possible, right? And so as a very brief pictorial tour, because I know we have a lot of wonderful speakers who go really in depth in many of these cases, we'll go through MIS TLIF, PTP, open deformity, single position lateral, MIS deformity, oncology, trauma, and cervical spine surgery, so all of these things. And of course, I understand I've got 15 minutes, right, to go over what's possible, so hold on to your seats. I may talk faster than Mike Wang when he's up there giving his talks too. So for the first, MIS TLIF, right? So now we've seen that a lot of data shows that robotics use decreased EBL. Some show that's actually more cost-effective than non-robotic surgeries, more accurate, less facet joint violations, less ASD. These were cases back from 2019 when I was doing more TLIFs back then, and this was the first video that was published in operative neurosurgery. Now this is like old hat now, but at the time in 2019, showing that you can use the robotic system so accurately to put in your screws. Once that screw goes in, the robotic arm then just moves to the next level and you can put in the next screw. It was like fascinating to start seeing. Now, when you move forward though, now with PTP, it's the same thing. So when you put that patient prone and you put in your screws, what's even better is now you can use the robotics navigation to do your prone lateral, right, which is actually very disorienting. So you have a case like this, 3/4 pars fracture, terrible MRI, patients, the robotic plan, right, shows the simulated inner body, put the position, patient prone, screws go in, right, very straightforward as Dr. Chua showed, and then you can use that navigation to put in the inner body. So this is the first x-ray I've taken, right, inner body cage is already in, you can see here screws already in, you leverage the navigation system for prone lateral, you get pre-op, post-op, right, so great restoration of height, and on the AP as well, right? So for PTP, very useful, similar to the MIS TLIF principles that initially powered the robotic system. Now, open deformity, right? So, the literature shows that especially when you compare robotics to less experienced to expert surgeons, there's no accuracy difference. So now you shorten the learning curve, especially for folks that are coming out and they want to do this stuff. The robot is more accurate with perfect screw placement compared to other techniques, and we showed through a systematic review, very, very accurate specifically for adult spinal deformity, 100% accuracy in S2 AI screws. So, we have a case like this. I was trained as an open deformity surgeon. We free-handed all of our screws, right? So it's very efficient. And back in 2019, I wasn't sure if the robotic system at that time could go up to T4, right? It was unknown. So this was a case where we did go up to T4, and I'll say that it is a bit longer, right, than freehanding in your screws, because the system has to register and you put all your screws in individually. But I'll say it was like the easiest thing to do, especially putting screws in through the fusion mass. So for open deformity, a very good application, especially for folks who are going higher up in the thoracic spine. Now, I will say in another case like this, prior surgery, terrible coronal deformity, he's got an extruded screw from his TLIF, and he's haloed out all of his S1. So the plan here is an S1 PSO. So to do an S1 PSO, you need at least 6 fixation points below that, so 3 iliac screws per side. And I'll say that this was the easiest part of the surgery, right? Because not only can I plan in 2 S2 AI screws per side plus an iliac screw, I can line it up with all this prior instrumentation, right? So I have no issues in lining up that rod, and I would say that the easiest part is bringing the robotic system, putting in the screws, and then doing like the miserably hard part, which is the S1 PSO. So you can see here, all right, well, I guess you can still kind of see, all the iliac screws go in, right? So perfect placement of those screws. You get a good correction here, and you can see, correction of the deformity, leveraging the accuracy of those iliac screws. So this is not in, out, in. There's no repositioning of the screws, so he gets a very good outcome with open deformity, right? Now, I would say that where you really start to shine with a robotic system is single position lateral. So when we talk about single position lateral, the data shows that it is an odd type of patient positioning, right? So Fayed et al. Wrote a really good paper comparing laterally placed robotic screws versus prone. And of course, as you would expect, the laterals had more breaches than the prone. We did our own study as well with our very first cases, so through our own learning curve. And we also showed that lateral breaches, we had 4.7%, prone breaches 2.9%. So still a 95.3% accuracy in lateral, but not as good as prone. And then we also did a systematic review showing that at least robots were non-inferior to other published techniques. So people who are publishing putting in laterally placed screws of fluoro or CT nav, we showed it was just as good. But with the robotic system, what we found is that we can now do simultaneous surgeries, right? So we published our series on OLIF, lateral ALIF. In the rare instances where you felt like you needed to go to the ilium, you can start putting in pelvic screws in lateral position. So just because you have to put in pelvic screws is no longer a reason to have to flip to prone. And the reason being is that now, although nav and fluoro you can place in lateral position, that is very technically demanding. You as the spine surgeon have to do that yourself. But with the robotic system, I can hand that over to my resident, or you can hand it over to a PA. And now I can do the lateral side. So now you have a simultaneous workflow to make this a very efficient operation. So for example here, the first case I'll show, right, just like Dr. Chua showed, 4-5 spondy, very, very common case. We have the robotic plan, simulate the inner body. You see the facet decortication there. This, so lateral decubitus, back is all the way to the edge of the bed, and this is the first x-ray, right? So screws are already in. I navigate in the entire process of the inner body. I shoot this x-ray that shows good placement of the inner body on lateral and AP. We have here the postoperative AP and lateral of an L4-5 OLIF, anterior to psoas, good restoration of height, stabilization, but the most important part, this is the time. The robot pin goes in at 8:49, drapes come down at 11:08. This is a 2-hour and 19-minute operation. Now, this is a lateral surgery, right? So what about the next case, 5-1 ismic spondy? Historically, for 5-1, you either have to do a TLIF or a supine ALIF, but if you're a lateral access surgeon, right, so ismic spondy there, you do the robot plan, simulate the inner bodies. I love lateral ALIF. I'll talk about it till I'm blue in the face. I do my own exposures. A beautiful surgery. You see here great exposure of the 5-1 disc anteriorly through like a 6-centimeter incision. So with this, you again have AP lateral. You have great stabilization, restoration of height. Again, for single position surgery, you have this. The robot pin goes in at 3:30. Drapes come down at 5:42. So now you have a 2-hour and 12-minute operation for what either is an MIS TLIF, which can be quite difficult at 5:1, or a supine ALIF and flip, but now you reduce it now to a 2-hour operation. Now, in that last piece of literature I showed, well, what about going down to the ilium? How far can we push this? You take a case like this, moderate deformity, PI-L mismatch of 38 degrees, PT of 48, and I asked myself, can you do this minimally invasively, and can you do this single position lateral? So we put it through the predictive algorithms, like, well, if we do this as all interbody cages, it actually puts him back into alignment as long as it's technically done well. So we plan this as an L2 to pelvis, simulate the interbody cages. You see everything lines up very well, and this is the surgery. All right, so 2, 3, 3, 4. I do O-lifts, anterior to psoas, so I'm standing in front of the patient. 2, 3, 3, 4, you have 4, 5 in front of the crest, 5, 1 as a lateral ALIF. You see here, this is the S2AI screw going into the left ilium, so down to up. Very straightforward using the robotic system. You can see here L2, S1, S2AI, everything lines up beautifully because it's robotically planned. My, not shown here, but actually my PGY2 passed this, right? So that's how straightforward it is. Great apposition to the pre-op plan. And you can see here, restoration. Now, I didn't get them perfect, right? Pelvic tilt is still 21, which may point out to the limitations of circumferentially minimally invasive surgery. But for this, no staples, no drains, no blood loss, no ICU stay, didn't open up his back, goes home on post-op day 4. So he still realizes a lot of the benefits of that MIS approach. MIS deformity, something that I also really love talking about because now we're really seeing the benefits of the robotic system. This was a paper earlier, Ueno et al., that showed that robotics is useful for less experienced surgeons. I would say that this is especially for minimally invasive deformity, right? I'm not Neil Anand or, Greg Mundis, Praveen Mumaneni, Dean Chow, all these people who have had a decade or more building this field. Like, I'm just coming out, but I still want to offer this to my patients because I believe that there's a place for it. So I was trying to figure out, well, how do we leverage robotics? There's no literature published on this, so we published it. So this is our experience using minimally invasive multiple rod constructs. Here's an illustrative case using robotics planning minimally invasively for degen scoli, and then our own preliminary experience as well, showing how robotics can leverage and enable MIS surgery. This was one of our cases that was in that data set. So BMI 42, not the best open deformity candidate. She's got a 53-degree curve. So I asked myself, can we do this minimally invasively then? So you can see here, and to Dr. Zemi's point, when you put in these interbodies from T12 down to S1, you see the lateral interbody cages derotate the spine. People used to always say this, and I never really thought about it, but you see the rotation of the coronal deformity on the left, you see the spinous processes all lined up on the right. So when you restore the disc space and stretch out all the ligaments that are there, the spine derotates. And so with this, these are through two, as you can see, 3-inch, 2.5-inch incisions for 6 interbody cages, especially in a woman this big. So now the rest posterior is purely circumferentially placed. So you see here, T9 down to ilium. You know, trained as an open deformity surgeon, I want a robust construct, especially for someone this big. So the plan is for multiple rods, which you can actually plan with the robotic system. This is her intraoperative long film fluoroscopy. And you know, prior to the placement of rods, we spin an O-arm to confirm that all the screws are appropriately placed. Here's actually the multiple rods there, so completely percutaneous. And you can see here, all of the screws are perfectly placed, so no repositioning needed. You'll notice her back is completely closed, right? So it's a circumferentially minimally invasive surgery. Don't have to open up the BMI of 42. And she gets a robust correction here, correction of her scoliosis, and then sagittally in balance. Now, the next case, similarly prior T12 to L2 Harrington rod fusion, you can see sagittal parameters, 59 degrees off, PT of 39, L1P, T1P, anything that you want to measure, he's sagittally imbalanced. Now, you take a look at this, and it looks like a pretty straightforward open case. Just open them up, do very aggressive PCOs, you can do a PSO if you want. But what I neglected to tell you is he's 73, he's got cardiac stents, his echo shows stable ischemic change, for which the cardiology says, no, he's cleared, trust us. He's on aspirin and Plavix, right? So you add all those things and you wonder, well, can I do this then minimally invasively? So what he ends up getting is a 2-3 OLIF, 3-4-4-5 ACR, lateral ALIF through several, 2-inch incisions here. You see actually great correction from just all of those interbody cages with those ALL releases. So through this, I tell myself, well, with that, we can actually just perk the back. So he gets an L1 to ilium. With ACRs, we know that it's going to be more stable with multiple rods, right, biomechanically. So he's planned with a multiple rod construct still placed transfascially. This is his intraoperative long film as well. So even though it's an MIS surgery, the robotics planning allows us to build all these complex constructs because we have the luxury of planning. So you have pre-op, post-op here, great sagittal correction through an MIS cage. You see all of his parameters, PT, L1, PA2, and PA. And you can see the amount of correction you can get through an MIS surgery. Last quick case I want to show for MS deformity, because as you know, I love talking about this. Another lady, 52-degree curve, and just as Roland showed, she gets an L1 to S1, right? So here it's through a 3¼ inch incision, you place in 4 interbody cages, lateral ALIF gets its own separate incision, and then through the robotics planning, although she has a residual curve, you can simulate that derotation by pulling that concavity over to that planar rod. So that's what she gets here, a bloodless surgery, right? So I also dissect down to the fascia. I'm handing this rod to my PGY2, right? So he passes this from T10 down to S2. But again, very straightforward because everything is already lined up. So here's her intraoperative long film. Again, great correction of her coronal deformity. She's pulled over, so for that residual scoli, she gets pulled over and straightened out. And then, of course, sagittal parameters all straightened out as well. So really leveraging the robotics technology to enable things like this, even in someone who hasn't been doing spine surgery for 10 years, right? So spinal oncology, lots of literature being published on the robotic system in use in cancer, but the case that I really want to highlight is one that leans on the accuracy of the robotic system. So we have this guy who's got a very rare epithelioid hemangioendothelioma. He's been irradiated, he's on active chemo, he has terrible mechanical pain. He can't stand for more than a minute, can't go to his daughter's volleyball games. So he comes to us, and my question is, he's being actively monitored for this. Can we stabilize him with carbon fiber? Now, all of you who've used carbon fiber know that carbon fiber is exceptionally unforgiving. That rod does not move. So how do we place this then minimally invasive, because I don't want to open up his skin. He's been irradiated and he's on active chemo. So with the robotic system, we can actually plan perfectly the heights of those screws, and with the heights of those screws, choose the appropriate carbon fiber rod with the same configuration. So you can see here, with that planning, the K-wires go in, all right, MIS surgery, and then he gets a carbon fiber system, carbon fiber rod, he gets an L2 to ilium percutaneous with the carbon fiber system. And you can see here great planning with that system, still able to get an MRI to follow his L4 sacral pelvic tumors, able to stand and live his life. Last application, spine trauma, very straightforward, right? So again, data showing here's an L1 burst fracture. A guy comes in as an Asia B, so he gets a mini open laminectomy at just where I want to do the laminectomy, facet decortication, and everything else. You can see here, a great win. You'll notice he came in an Asia B, sensation, not moving his legs, comes back 8 months later. You can see this is a standing film. Right, gets down to an Asia D. So great outcome for him. But really, what's beautiful about the robotic system is, just like I showed for single position lateral, T12 burst fracture, what you can also do is a single position lateral corpectomy, right? So Rod gives beautiful presentations on lateral corpectomies, pro and lateral corpectomies. If you know how to take out that fragment from the side, then what you have now is you put in your screws, one above, one below, you do your corpectomy, take out that pedicle, take out that fragment, and what you have now is a single position lateral corpectomy and cage. You don't have to open up the back. So you see here, pedicle comes out, you do the corpectomy defect, you take that fragment, push it out, you've decompressed the spine from the front, and you'll notice here, there's no laminectomy that's needed. So you don't have to flip, you don't have to open up the back, that fragment's gone, you get restoration of height, And again, it's really enabled with a robotic system to be able to place those screws, navigate the rest of the corpectomy. Last, cervical spine surgery. So this is actually being done. So you can see here, Casinde et al., I believe it is, they put in 88 pedicle screws, 14 breaches. All of them were medial, right? So the medial breaches are the safest, right? So next was Pham et al. They actually did a randomized trial, believe it or not, robot versus fluoro. Robot had 88% perfect pedicle screws compared to fluoro, 61%. This is actually a new robotic system out of Korea showing 97.5% accuracy with a robotic system, 40 pedicle screws. We did our own retrospective review of all the available literature. Again, very, very accurate with the current generation of robotic systems with less than 1 millimeter deviation. Now, we also tried it as well with the current generation. So we hooked up the robotic system, planned our screws as a percutaneous C1 to C3, got as far as the registration. We almost were able to register it, couldn't get it in our early experience, so we navigated the rest of the C1 to C3. But you can see that we are thinking about designing sleeves for this to make this applicable. So to the point where we think about cervical spine surgery as a potential limitation, with the current systems, it's definitely doable. All right, we're still there. We went through seven different types of cases. So the whole point of this talk, we're talking about limits. And again, defining those limits is really found by first showing what is possible. And I would say that if we're looking about currently, what you're able to do, right? You're able to put in pedicle screws. That's missing sort of the bigger picture about robotics platforms, because really what we're talking about is a single moment in time. It's easy to forget that it was only just over 10 years ago that robotic spine surgery used to be out of a Coke can, right? Renaissance system. Now you look, and every single robotic system are these multi-jointed 6 degrees of freedom arms that really leverage navigation. And as a moment in time, I would say that we are here, right? And so when you think about the next generation systems, they're being developed right now in the basements of all these big companies as they're thinking about the future. So to the point where we're asking, well, what are the limits of robotic surgery? I mean, I'm biased, but I would tell you that when you think of the technology that's available in industry, right, that's finally coming to medicine and spine surgery, well, what are the limits of robotic surgery? Well, I would say in a very biased sense, sky's the limit, right? Your imagination's the limit. And really, there's a lot of things that we can do and still will do with time, right? So thanks so much.
As always, outstanding. Thank you so much for being here and showing us the sky being the limit. Now I'm going to go back to my origins. When I was a young spine surgeon in the 1990s, you weren't born yet, we were accused of doing too many spine fusions.
Yeah.
Now, as an aging spine surgeon, I have the same question again. In my clinic, half of the patients are patients who've had fusions. And when I look at the origin films, I always like to do that. I go like, why was this patient fused? I see an awful lot of L3 to 5 fusions, which this hardware is safely placed through navigating enabling techniques. Very telling word, by the way, enabling techniques.
Yeah.
And they did not have anything close to the deformity corrections that you had, which is, by the way, worthwhile discussing in a separate topic. But they had fusions done for reasons that I really don't understand, where a decompression or nothing would have been very apropos. So are we kind of fulfilling the wishes of another force, maybe industry, to do more fusions, put more hardware into patients, where a well-crafted decompression, whatever our technique is, might have been more appropriate? What are your thoughts on that?
I think it's always a great philosophical discussion, right? I mean, I think historically doing fusions required a very high technical skill set. So then it was limited to maybe the elite level of surgeons who'd get there, who then would naturally police themselves in terms of indications, right? It's sort of like back when cars were only manual transmission, you really had to have a high level of entry to be able to drive a car. And now, you can give like a 16-year-old, like a Tesla, that goes 0 to 60 in like 2 seconds, right? And so it is putting very phenomenal tools into a lot more surgeons' hands. But I do think then that it allows us to, now that we don't have to think about so much about the technical executions of things, we have more time to think about those indications. And I do agree that just because something is easier doesn't necessarily mean that something should be done. But it does allow us to focus more of that time, right? When you look at the literature from like the late 1990s into the early 2000s, there's so much literature on how to safely place pedicle screws, right? That has been obviated now. And that gap, I feel, can now start to talk about the indications how to do that correctly now that we can actually instrument the spine in a much safer way.
Martin, can I just say that was outstanding. It's such an interesting.
Microphone.
Oh, sorry. Here. Thank you. That was such an outstanding discussion and presentation of what can be done. I would just say this is amazing to push initial virgin surgery. But as we know, the problem half the time is that we deal with complex revisions where things have not gone well. And we can hybridize robotics into it to improve the situation. But for me, in my practice, where it falls apart, I think you do it better than anyone else, is the cases where I just can't see past the need to open to achieve some goals like osteotomies and other things. And I have no doubt that we'll eventually get there. But where we are right now, this seems to be a stumbling block for the next step for me.
Yeah.
Do you have any thoughts on that?
Yeah, I think there are going to be limitations to robotics. I don't think, Rick gave a great example about urology, and probably all, say, prostatectomies are robotic now, right? I don't know if spine surgery is always going to have an entirely 100% robotics types of surgery. For the neurosurgeons in the room, it's like aneurysm clippings, right? So a lot of it is treated with endovascular techniques, but there's always going to be a role for open clip ligation of complex aneurysms. I think robotics is a phenomenal tool, right? Just like autopilot in a Tesla. You can put in multiple destinations and it'll take you there. But there's always going to be a role for a manual type of operation. And when we talk about complex revisions, right, where you have to go in and open, when you talk about 100-degree scoliotic curves, now these are diagnoses. So I wonder, to answer your question, if, say, there may be a point where, say, all degen surgery can be done with robotics, is you don't have to necessarily open up the spine. There's interbody techniques where all oncologic surgeries, where you're stabilizing, can be mini open separation surgery, or percutaneous stabilization, where you don't have to do like a big en bloc. So I do think that there are areas that robotics can be helpful, but just like anything else, it is a tool, and the tools are becoming better and better. But I think there's always going to be a role for other techniques, especially for the pathologies we're treating. Right. Thanks for that question.